history of the autonomic nervous system and the terminology that we use goes back a little over 100 years when John Newport Langley coined the term autonomic nervous system. And he described both the sympathetic and the parasympathetic and the enteric nervous system components of the autonomic nervous system. And that was his term. When we hear the word autonomous, we often think independent. But that's not really the way to think of these functions of the nervous system. These are not things that are independent. In fact, they're highly integrated with one another and with the other functions of our nervous system. Now, they are self-regulating and they are unconscious. Hence, the term automatic nervous system could be used instead of autonomic nervous system. So John Newport Langley described the sympathetic nervous system, the parasympathetic nervous system, and the enteric nervous system. It was a few years later that Walter Cannon made the differentiation between the sympathetic adrenergic system and the sympathetic noradrenergic system, and recognized that those involved two different neurochemicals. Henry Dale described the sympathetic cholinergic system that is responsible for producing sweat in humans. So we have these 5 individual systems that make up the automatic nervous systems. We talked about the synapses between neurons. The way that neurons use synapses to communicate is by releasing neurotransmitters. So as we look at the main components of the parasympathetic nervous system, the vagus nerve and the pelvic parasympathetic nerves, there's a nerve that, or a neuron that leaves the central nervous system and a synapse between a presynaptic neuron and a postsynaptic neuron. The neurons of the autonomic nervous system use acetylcholine as the neurotransmitter between the presynaptic and the postsynaptic neurons. So acetylcholine is the neurotransmitter at the synapses of the autonomic nervous system. And that's true whether we're talking about parasympathetic nerves or we're talking about the sympathetic nerves. Sympathetic nerves also use acetylcholine for communication at the synapse. The parasympathetic nervous system also uses acetylcholine to carry out its effects at the effector site. The sympathetic nervous system uses norepinephrine to carry out its effects at the effector site. So a presynaptic neuron communicates with a postsynaptic neuron using acetylcholine, and then the postsynaptic neuron, in the case of the sympathetic noradrenergic system, releases norepinephrine. The postsynaptic neuron, in the case of the parasympathetic nervous system, releases acetylcholine. A moment ago, we talked about Walter Cannon, who described the sympathetic adrenergic system. The adrenal medullary cells produce adrenaline. The adrenal medullary cells arise from the same embryonic tissues that give rise to other neurons. So I think of adrenal medullary cells as neurons that forgot that they were neurons. And so instead of acting like neurons, they act like an endocrine gland. They release a neurotransmitter, but instead of releasing it directly at an effector site, they dump their neurotransmitter into the bloodstream. So to review, the parasympathetic nervous system uses acetylcholine at its effector site. The sympathetic noradrenergic system uses norepinephrine at its effector site. The sympathetic adrenergic system uses epinephrine at its effector site. Norepinephrine is also called noradrenaline. Epinephrine is also called adrenaline. They get extra names to make it extra confusing for everyone. Now, it's not really to make it extra confusing, it's just a difference between Greek and Latin. Epinephrine, because epi upon the nephros, kidney in Greek, is the same as adrenaline, ad next to the renals, kidneys in Latin. Norepinephrine is the mommy neurochemical of epinephrine, or adrenaline. And the sympathetic cholinergic system, similar to the parasympathetic system, uses acetylcholine at its effector sites. Now, the enteric nervous system uses a whole lot of different neurotransmitters within the gut. In fact, there's more serotonin and more dopamine in the gut than there is in the brain. So the enteric nervous system is the nervous system that's responsible for digestion, for bowel motility, gastrointestinal motility, and control. So that's the peripheral aspect of the autonomic nervous system. And all of that peripheral part of the autonomic nervous system is regulated by what we call the central autonomic network. Multiple nuclei or individual areas of the brain that work in a coordinated fashion to regulate the functions of the autonomic nervous system. You don't have to memorize this slide. There will not be a quiz later. So we're going to talk a little bit of epidemiology here. So as we talk about rare diseases, we want to know what a rare disease is. We use terms like incidence and prevalence. Incidence is the number of new diagnoses of a particular condition. So usually incidence is given in a number of new cases in a year out of so many people. So an incidence for a certain disease might be 32 new cases per 1,000 people per year. So it's a rate. Incidence is a rate. Prevalence is the number of cases in a population at a given time. So prevalence is simply a number. So how do we define a rare disease? So where do we draw our line in the sand? Where do we make the cutoff for a rare disease? And the cutoff varies. Back in 2002, the Congress of the United States passed the Rare Diseases Act, and that act defined a rare disease as affecting less than 200,000 people in the United States. So that would be about 1 in 1,500 people. So according to that, if a disease affects less than 1 out of every 1,500 people, it's a rare disease. The European Commission on Public Health defines a rare disease as a disease that generally affects fewer than 1 in 2,000 people and generally is life-threatening and or chronically disabling. So fairly similar numbers, 1 out of every 1,500 or 1 out of every 2,000 people. So the cutoff for defining a rare disease is actually not that uncommon. I think most of us went to a high school with about 2,000 people. Then a rare disease, any given rare disease, is probably going to affect 1 person out of the high school that we went to. Just to put that in overall context. As we go forward and talk about specific rare forms of dysautonomia, I really want us to remember that diseases of the autonomic nervous system are not rare. So dysautonomias are quite common. There are some rare conditions that cause rare forms of diseases of the autonomic nervous system, but as a whole, diseases of the autonomic nervous system are very common. They are often under-recognized and underdiagnosed, and probably most of our listeners can appreciate that. but autonomic disease is common. So let's talk about some uncommon forms of dysautonomia. So familial dysautonomia historically was called Riley-Day syndrome. We also call it hereditary sensory and autonomic neuropathy type 3. So I'm going to say that again, hereditary sensory and autonomic neuropathy type 3, because that tells you what this is. It's a neuropathy, a problem with the nerves that affects the sensory and the autonomic nerves, and it's hereditary. So familial dysautonomia is a very specific condition caused by a very specific mutation, and it's in the general population very rare. So familial dysautonomia refers to this one specific genetic condition. It does not mean a dysautonomia that runs in a family. So just because a mother has a dysautonomia and one or two of her kids has a dysautonomia, they may have a cause of their autonomic disease that is familial, but it is not familial dysautonomia. So that term is reserved for this very specific condition. So familial dysautonomia is caused by a mutation in a gene called IKB-cap. And there are only about 300 cases in the world right now, and they occur in people of European Jewish descent. The disease has not ever, as far as I know, been shown to occur in a person that is not of European Jewish descent. And so this disease really is rarely seen outside of areas with large populations of people of Jewish descent. And so the centers that really see the most of these cases are at NYU and in Israel. The young people with familial dysautonomia are pretty profoundly affected. They don't make tears. They are insensitive to pain, and this leads to tissue injuries and self-destructive behaviors. And because the sensory aspect of their autonomic nervous system is impaired, they have wide fluctuations in their blood pressure because they don't have the feedback to regulate their blood pressure. There are other hereditary sensory and autonomic neuropathies caused by various gene mutations. And these are diseases that appear in the pediatric age group. So these are diseases that are diagnosed in children, and these children tend to be pretty profoundly affected. These diseases affect, again, their sensory nerves as well as their autonomic nerves. And these children have pretty profound disability. So we're going to talk about some disorders of neurotransmitter synthesis within neurons. So we talked about those neurotransmitters. They're important for communication at synapses between neurons and are important for the nerves to be able to do their job at the effector sites. We talked about norepinephrine as the main neurotransmitter of the sympathetic nervous system. Norepinephrine is in the family of chemicals called catechols. Its precursor, dopamine, is also a catechol. Dopamine is made from a precursor called dopa, which is made from tyrosine. The enzyme dopamine beta hydroxylase is responsible for converting dopamine into norepinephrine. There's a specific disease called dopamine beta hydroxylase deficiency, a rare disease in which this enzyme that produces norepinephrine or converts norepinephrine from dopamine is not present. And so norepinephrine levels drop dramatically. Well, we can take advantage of a neurochemical trick in treating people with dopamine beta hydroxylase deficiency. So recognizing that this is the enzyme that's affected, so dopamine is not converted to norepinephrine, we can use this enzyme, dopa decarboxylase, and the chemical L-DOPS, which is also called droxidopa, or its commercial name Northera. Dopa decarboxylase, this enzyme that converts dopa to dopamine, will convert L-DOPS directly into norepinephrine. And this is an effective treatment for those very rare people that are affected by dopamine beta hydroxylase deficiency. So how do you diagnose dopamine beta hydroxylase deficiency? Well, it goes back to the fact that norepinephrine is not synthesized by the neurons, so norepinephrine levels are profoundly low, and the breakdown products of norepinephrine are profoundly low. And so you have high dopamine levels, low norepinephrine levels, and we can measure those in the bloodstream to make the diagnosis of dopamine beta hydroxylase deficiency. Another rare condition called Menkes disease is caused by a mutation in the copper transporter. Copper is a necessary cofactor for dopamine beta hydroxylase. And if copper is not there to help dopamine beta hydroxylase do its job, norepinephrine isn't made. So norepinephrine and its breakdown product, those levels go down, and dopamine levels and the breakdown products of dopamine go up. Children with Menkes disease can be treated effectively with copper supplementation, but it needs to be started early. And so this is a disease for which getting the neurochemical diagnosis early is very important. Another genetic disease that affects the autonomic nervous system is Fabry's disease. Fabry's disease is caused by a mutation in the alpha-galactosidase A gene, which is on the X chromosome. So predominantly men are affected. Alpha-galactosidase is responsible for breaking down some specific chemicals, and when they're not broken down and handled appropriately, they build up in blood vessels and other tissues and cause findings in the eyes, specific findings in the skin, and can affect the small fiber nerves. The nerves of the autonomic nervous system are small in diameter. When we talk about small fiber neuropathies, we're referring to those nerve problems that affect the nerves that are small diameter and have no insulating myelin sheath or a very thin insulating myelin sheath. And they differ in the way they look clinically and often in the things that cause them from the large fiber neuropathies. The nerves of the autonomic nervous system are small fiber nerves. The nerves that carry pain and temperature sensation are small fiber nerves, as opposed to the nerves that are responsible for carrying signals to our skeletal muscles. Those are large fiber nerves. And the nerves that are responsible for carrying information about joint position sense, vibratory sense, and some of our other sensory modalities that we're aware of, those are large fiber or large diameter nerves. So Fabry's disease causes a buildup of a specific chemical that affects small fiber nerves. And like I mentioned, it's carried on the X chromosome. So if you remember from biology, women have 2 copies of the X chromosome, men only have 1. So men tend to be predominantly affected, but women can be symptomatic carriers. So if there's a concern for Fabry's disease, and that concern would come because of characteristic skin findings, eye findings, and or a family history that might suggest the disease, gene testing can be done. The actual enzyme activity can be tested in males. So moving on to another genetic cause of small fiber neuropathy. All of our neurons have channels in their membranes. So the structure of a neuron has channels that let different ions rush in and out for the nerve to perform its function, for the neuron to perform its function. Sodium channels are a very important part of neuronal function. And the sodium channels, as you can see in this illustration, have a bunch of different subunits that are embedded within the membrane of the cell of the neuron. We've learned that a mutation in one of these subunits, the 1.7 subunit of the voltage-gated sodium channel, is a one mutation that can cause small fiber neuropathies. We don't have a good sense for how common this is, but about 5 years ago, this group from the Netherlands looked at people with diagnoses of small fiber neuropathy of unknown cause, and they found that about 1/3 of their population had mutations in this SCN9A gene. This is something that hasn't been replicated in larger populations, so something that remains to be studied so that we can know how to better test for this gene and know when to test for it. So we're going to jump from genetic conditions to conditions that we typically think of as neurodegenerative. I'm going to start by talking about a group of diseases called the synucleinopathies. Alpha-synuclein is a protein that is normally found in neurons. There are diseases in which that alpha-synuclein protein builds up abnormally within neurons and is associated with death of specific neurons. And the prototypical synucleinopathy, prototypical synucleinopathy is Parkinson's disease. So the PD is for Parkinson's disease. So a problem with the alpha-synuclein protein. There are other diseases that we classify as synucleinopathies, and one of those that we're going to talk about is pure autonomic failure. So this is a disease that was originally described by two guys called Bradbury and Eccleston, and they saw a group of people that had orthostatic hypotension, so a fall in their blood pressure, without any evidence of central neurodegeneration. So they didn't have a movement disorder, they weren't having dementia, they didn't have motor problems, they just fainted when they stood up. Pure autonomic failure is caused by a loss of those sympathetic noradrenergic nerves. And so people get neurogenic orthostatic hypotension. So we're going to talk about orthostatic hypotension and what is neurogenic orthostatic hypotension compared to other things that can cause a drop in blood pressure when people stand up. Neurogenic orthostatic hypotension comes when the body's reflexes to increase blood pressure aren't working appropriately. So normally, when blood pressure falls, that drop in blood pressure is communicated to the brainstem. We'll look at a graph of it here. So when blood pressure falls, that drop in blood pressure is communicated to the brainstem, and the brainstem sends out a signal for the blood vessels to tighten down and get the blood pressure back up. People with neurogenic orthostatic hypotension, either that information isn't getting to the brain, or the brainstem doesn't care about the drop in blood pressure, or the signal's not getting out through the sympathetic nerves, or the communication between the sympathetic nerves and the muscle and the blood vessels that helps the blood vessel squeeze down isn't there. So that loss of that normal reflex will cause neurogenic orthostatic hypotension. But other things will cause an abnormal fall in blood pressure with standing, like having low circulating blood volume. If your adrenal cortex that produces cortisol isn't working right, that will cause a drop in blood pressure. Chemicals within the body that make the blood vessels dilate or open up will drop the blood pressure. And the biggest offenders, medications, medications, medications. So people are put on a lot of medications that will cause their blood pressure to drop. And that's a lot more common than these other things. So we're able to differentiate neurogenic orthostatic hypotension from other things that cause orthostatic hypotension by looking at that blood pressure control reflex. And we do this in the autonomic testing lab by having a patient perform a Valsalva maneuver while we're measuring beat-to-beat blood pressure. And so you can see this normal reflex of blood pressure dropping. The brainstem says, hey, where's my blood pressure? And there's a reflexive narrowing of the blood vessels to cause the blood pressure to come back up. In someone with neurogenic orthostatic hypotension causing a failure of that reflex, the blood pressure falls and falls and falls without any reflexive increase in the blood pressure. There are other clinical cues when we see someone who might have pure autonomic failure, that's what we may be dealing with. Dream enactment behavior, so acting out dreams, is often seen in specific cases of synucleinopathies. So Parkinson's disease with orthostatic hypotension and pure autonomic failure are often accompanied by dream enactment behavior. And a loss of sense of smell. What we could use a fancy Greek term, hyposmia or anosmia, to describe a loss of sense of smell. And that is often seen in these forms of alpha-synucleinopathy. A cousin of pure autonomic failure is multiple system atrophy. And in multiple system atrophy, individuals have sympathetic noradrenergic failure similar to pure autonomic failure, but they also have evidence of central neurodegeneration. They'll develop problems moving consistent with Parkinsonism or with problems of their cerebellum. We often see other disturbances of motor function, and people with multiple system atrophy very often have urinary involvement early on in the course of their disease. We can differentiate multiple system atrophy from pure autonomic failure clinically very often because the sense of smell remains preserved in multiple system atrophy. We can also use neurochemical and neuroimaging techniques to help differentiate multiple system atrophy from pure autonomic failure. And what I want you to pay attention to at the bottom here are these fluorodopamine PET scans. So in a fluorodopamine PET scan of the heart, in a normal person, we see rich sympathetic innervation of the heart. In someone with pure autonomic failure, we don't see a fluorodopamine-derived signal. So they've lost that sympathetic innervation of the heart. In multiple system atrophy, the sympathetic innervation of the heart remains preserved. And while most centers don't have access to fancy PET neuroimaging, positron emission tomography neuroimaging, similar sympathetic imaging of the heart can be done using SPECT, what's called SPECT, a technique that's available at most medical centers. So not too long after the description of pure autonomic failure, cases were recognized that looked clinically similar to pure autonomic failure, cases in which individuals had involvement of all of their autonomic nervous system, described as a pan-dysautonomia, because everything was affected. So people with what we have come to call autoimmune autonomic ganglionopathy have this disorder in which all of their autonomic function is greatly decreased. But from a neuroimaging basis, these patients with what we now call autoimmune autonomic ganglionopathy, though they looked clinically a lot like the pure autonomic failure patients, their sympathetic neuroimaging showed intact cardiac sympathetic innervation, showing us that this was a very distinct disease. And it was a few years later that Steve Vernino, while he was still up at Mayo Clinic, identified the antibody that causes this disease. So we go back to our little schema here of sympathetic and parasympathetic neurotransmission. We talked about these synaptic connections. Autoimmune autonomic ganglionopathy blocks these receptors at the synapses so that the sympathetic and parasympathetic nervous system signals can't get through. The central nervous system is doing its job. Those preganglionic or presynaptic neurons are doing their job. They're releasing their neurotransmitters, but the neurotransmitter signal is getting blocked. So the parasympathetic system is wiped out and the sympathetic system is wiped out. Even though the neurons are there, they are there, the signal is just not getting through. There are clinical cues which make us think about autoimmune autonomic ganglionopathy. The clinical scenario is predominantly that of a very profound again, that word pan-dysautonomia. All of the functions of the autonomic nervous system are affected. And so we can test for the antibodies, and that antibody testing is commercially available. And when we find those antibodies, that's what we treat. And we can use therapies that target those autoantibodies to clear them from the body, either by filtering them out, giving intravenous immunoglobulin, or using immunosuppressive agents, or a combination of those. At the same time, we focus on supportive treatment that lets us promote that cholinergic signaling, promote that signaling of acetylcholine. And we also use therapies that augment blood pressure directly or indirectly to treat the orthostatic hypotension associated with autoimmune autonomic ganglionopathy. Now, it is worth noting a little bit about that autoimmune autonomic ganglionopathy antibody. That antibody is present in low concentrations in about 5% of people in the population. People with the clinical syndrome of autoimmune autonomic ganglionopathy have higher concentrations of that autoantibody. So a low concentration of the antibody doesn't mean someone has autoimmune autonomic ganglionopathy. A clinical presentation consistent with autoimmune autonomic ganglionopathy plus a high concentration of the antibody is consistent with the diagnosis of AAG. There are other diseases that are due to antibodies within the body affecting the autonomic nervous system. And one of those is a condition called Lambert-Eaton myasthenic syndrome. So acetylcholine is not just a neurotransmitter of the autonomic nervous system. Acetylcholine is also the neurotransmitter that neurons use to talk to muscles and make muscles move. People with Lambert-Eaton myasthenic syndrome develop muscle weakness. And we can diagnose Lambert-Eaton myasthenic syndrome with a combination of clinical and electrodiagnostic findings. So people with Lambert-Eaton myasthenic syndrome, in addition to having muscular weakness, develop autonomic symptoms of dry eyes and dry mouth, constipation, and feeling lightheaded when they stand up. We can use repetitive nerve stimulation to look for evidence of this neuromuscular junction problem in Lambert-Eaton syndrome. Often we will see with repetitive nerve stimulation a drop-off in the motor response. So that's what we're showing in this patient's example. This patient did not have a drop-off, but we stimulated a motor nerve and looked at the motor response, and she had a relatively low amplitude response. After we had her exercise for 10 seconds, her motor response increased dramatically. And you can see in the bar graph below that it increased more than twofold. And that's characteristic of these presynaptic neuromuscular junction problems. So I use that term presynaptic. What does that mean, and how does that tie into Lambert-Eaton myasthenic syndrome? So the diagram here is showing a neuron, so that the end of a neuron, so a presynaptic terminal, where it communicates with a muscle. So we've got muscle down here below, the end of a neuron above right here. Neurotransmitters are packaged into little packets we call vesicles. Vesicles are released when calcium comes into the nerve terminal and causes one of these vesicles to fuse with the neuron membrane and release its neurotransmitter into the synaptic space. So the neurotransmitter of the neurons that communicate to muscles is acetylcholine, just like we talked about with our presynaptic neurons of the autonomic nervous system. So when we want a muscle to fire, the neuron releases its acetylcholine. The acetylcholine travels across this synaptic cleft and binds to acetylcholine receptors on the muscle, stimulating the muscle to contract. In Lambert-Eaton myasthenic syndrome, an antibody blocks that calcium channel. So calcium doesn't get in to make the vesicles fuse with the presynaptic nerve terminal membrane, so acetylcholine is never released. When we diagnose Lambert-Eaton myasthenic syndrome, we recognize that the condition is often seen in association with cancers, particularly small cell lung cancer, and so we look for and treat that cancer if we identify it. And much like autoimmune autonomic ganglionopathy, our focus in Lambert-Eaton syndrome is to remove the antibodies that are causing the problem, either by filtering them out, giving intravenous immunoglobulin, or immunosuppressant medications. We can also use medicines that stimulate acetylcholine's signaling, like pyridostigmine, also called Mestinon, or 3,4-diaminopyridine. There are other dysautonomias that are even more rare that are caused by autoimmune autoantibodies, including those against HU, also called ANNA1, voltage-gated potassium channels, CRIMP5, and anti-GAD antibodies. You don't have to memorize those, but here, this was just in February's edition of Clinical Autonomic Research, recently described autonomic neuropathy associated with GAD autoantibodies. And this is an evolving field. We're still learning when and how often to look for those autoantibodies. And I'll take a moment to make a side note. So we often say autoantibodies. We recognize that many of these are associated with cancers, and we also use the term paraneoplastic antibodies. So neoplasm meaning cancer, paraneoplastic related to cancers. So paraneoplastic or autoimmune antibodies. And like I mentioned, this is a field of ongoing research. Many of you are familiar with Dr. Kem's work and the identification of evidence of antibody-mediated activity against beta-adrenergic receptors. There's some emerging evidence of autoimmune, of possible antibody-mediated effects on cholinergic receptors. This Mayo Clinic group reporting on autoantibodies associated with specific proteins in the heart in people with POTS. So a very evolving field at this time, and hearkening back to Lauren's comment at the introduction to the webinar, definitely something that needs more funding as we go forward. Autoimmune conditions can also damage small fiber nerves directly. As we looked back at the first 103 patients referred to our military autonomic disorders clinic, 10 of them had confirmed autoimmune disorders. And these 10 were part of a group of about 60 patients that had evidence of an autonomic neuropathy. So of just over 60 patients with an autonomic neuropathy, 10 of them had confirmed autoimmune disorders. So I would not put this in the box of, or at least I would not put most of these in the box of rare conditions. And as we looked at what those autoimmune disorders were, 2 out of the 10 had a confirmed diagnosis of Sjogren's syndrome. 3 out of the 10 had undifferentiated connective tissue disease. 1 of them had sarcoid. 2 of them had lupus. And 2 of them had 2 diseases that really are rare: adult onset Still's disease, which is incredibly rare, and Behçet's syndrome. It is worth, I think, commenting on Sjogren's disease because it is not a rare syndrome. As we look at causes of small fiber neuropathies, once we remove diabetes and alcohol, in the majority of cases we don't identify a specific cause. But in those cases in which we do identify a specific cause, at this time it appears that Sjogren's syndrome or Sjogren's disease is the most common cause. And numbers vary, but it's probably around 3 to 4% of people with small fiber neuropathies. So again, not a rare syndrome, but one that definitely needs to be pursued diligently in diagnosis. And I put the note up here to not forget about celiac disease, because that has been shown to be associated with nerve problems, neuropathies in general, and also small fiber neuropathies specifically. Another rare condition that affects autonomic nerves, primarily in adults, is a condition called amyloidosis. So amyloidosis refers to abnormal deposition of proteins in the tissues of the body. And this can be caused by overproduction of specific proteins or by mishandling of proteins. And the most common cause that we think of in autonomic neuropathies is familial amyloidosis, which is due to a specific mutation in a gene called transthyretin. Amyloidosis is diagnosed histologically, so by looking under a microscope at tissues. We often will do a biopsy of the fat in the abdomen when we are particularly concerned, but looking for evidence of amyloid in the skin is also routinely done. And specific staining techniques are done to allow identification of amyloid protein in tissues when we look under a microscope. Another very rare condition that can affect small fiber, autonomic, and sensory nerves is porphyria, a mishandling of breakdown products of protein. So I put the picture of Vlad Tepes, who is also called Vlad the Impaler, up here because some people have posited that he had porphyria, and that led to his insanity, and also may have led to legends about vampirism, as some forms of porphyria are associated with development of skin lesions when individuals are exposed to sunlight. In addition to the nerve problems that are seen in porphyria, people with porphyria have symptoms outside of the nervous system. A prominent clinical symptom is recurrent abdominal pain. And one of the keys to diagnosis of porphyria is that, particularly during a period of clinical symptoms, the urine will turn color when exposed to sunlight. So we saw normal colored urine turn a red or reddish brown color when exposed to light. So another rare condition, jumping from a hereditary cause to a typically infectious cause, is botulism. So we've got our picture up here again of the nerve synapse talking to muscle, so that neuromuscular junction. Botulism is caused by the presence of proteins that prevent the vesicles inside the presynaptic neuron from fusing with the neuron membrane and releasing their contents. So all of the acetylcholine gets stuck in the presynaptic terminal, and that affects the muscles, and that's the most life-threatening portion of botulism, because the muscles become paralyzed and the individual affected is unable to breathe. But because all acetylcholine signaling is affected, people with botulism also develop profound dysautonomia, and that is often a clue in the diagnosis. When their pupils become reactive and their mouth becomes dry and they develop severe constipation, that's a clue in the diagnosis of motor weakness that someone might have botulism. There are infectious diseases that can predominantly affect the small fiber nerves. So leprosy, the disease caused by Mycobacterium leprae, does affect predominantly the small fiber nerves. There are typically cutaneous or skin manifestations with leprosy. And the picture of the armadillo is here because armadillos are a natural harbor of Mycobacterium leprae. So HIV infection does affect autonomic nerves. Typically the autonomic effect of HIV infection is not apparent clinically, but it can be pretty consistently picked up on formal testing. There are only a couple of studies that have really looked at that. Most patients with HIV don't develop overt dysautonomia. Another rare infection, at least in our country, of autonomic neuropathies is Chagas disease. So an infection with Trypanosoma cruzi, which is acquired when people are bitten by a specific insect that lives in South America. Chagas disease is accompanied by symptoms outside of the nervous system as well. So rare infectious diseases that can affect the autonomic nerves. As we talk about infectious diseases, it's also worth mentioning Lyme disease. So Lyme disease can be associated with a neuropathy. Lyme disease can be effectively treated with antibiotics, and we know that with the appropriate course of antibiotics, the disease, the infection is eradicated from the body. So we talked about the autonomic nervous system. We talked about its structure, both the central autonomic network and also the peripheral autonomic nervous systems. We talked about the synaptic or ganglionic neurotransmission between presynaptic and postsynaptic neurons. And we talked about the release of neurotransmitters of the different components of the autonomic nervous system at their effector sites. We talked about a variety of rare diseases that affect the autonomic nervous systems, but we also highlighted the fact that while there are many uncommon forms of dysautonomia, dysautonomias as a whole are not uncommon. So I think we're right on time to go through some questions. We've had a few questions that came in ahead of time, and then we can take some questions for those that are in attendance. If over on your control panel there is a space to type in messages and questions, and you're welcome to type in questions there, and we will see which ones we can get to. The first question that came through ahead of time was in regards to mal de débarquement syndrome, and please pardon my French accent. So mal de débarquement syndrome occurs when people have been on some type of moving object for a relatively prolonged period of time. So the French mal de débarquement, so mal, badness, of débarquement, so disembarking. So this is described when people have been out on a boat or on a ship and they come back to land and they have a persistent sensation that things in the environment are still moving, so like they're still rocking on a boat. And that can last for days or even weeks. Most of us have had the experience of being out on a boat or a ship or visiting the amusement park, and for the next day or so we still feel like we're moving. And that's pretty typical. So our balance system, our vestibular system, is constantly adapting itself. And when we're put in a condition of movement, the vestibular nervous system, that balance system, tries to adapt. And when we leave that situation, it takes a few hours, a couple of days for that vestibular system to reset itself. Mal de débarquement syndrome is a condition in which that resetting doesn't happen the way it should. So we don't consider it a form of dysautonomia. We do consider it a vestibular disorder, so a disorder of the vestibular system or the balance system.
Hey, Dr. Cook, while you're going through the questions, I wanted to ask the audience a question. We have a poll. We just wanted to sort of get some feedback from our guests on what their interest is in dysautonomia, whether they're a patient or a caregiver or a medical professional, just sort of help us understand who's checking out our webinars. So I'm going to really quickly just launch a poll, and if everyone could just take a few seconds to answer if you'd like to. And we'll have the answers pretty quickly.
This is great. I'm very curious to see this.
Okay, I'm going to close it in a few seconds, so if you haven't clicked yet, it's still going up. I see 80% of you have voted, so there's a reluctant 20% of guests. Okay, so 70% of patients, 70% of our guests are patients, 20% are caregivers or relatives. 9% are medical professionals, and the rest is other. So that's a pretty good breakdown. Thanks for participating, and I'll turn it back over to you.
Great. Thanks, Lauren. All right. So another question that came through, Janice wrote, as a patient diagnosed with dysautonomia with a tilt table test and small fiber neuropathy with a sweat test, what types of questions should I be asking, and what additional tests should I expect my doctors to consider? Well, this opens up the door to talk a little bit more about history taking in disorders of the autonomic nervous system. As we think about these many different things that can cause a small fiber neuropathy, we approach it kind of like bloodhounds sniffing out a trail. And there are certain patterns that are seen in many of these conditions. So the specific tests that are going to be done are going to be based on the timing of onset, so the onset of the symptoms of small fiber neuropathy, how the small fiber neuropathy has progressed or hasn't progressed over time, what components of the autonomic nervous system are affected, and any other associated conditions like skin manifestations. Family history is often very important. And so I think the two questions that I ask in a clinical scenario when I'm seeing someone with small fiber neuropathy that I think we should ask is, number one, why is there evidence of nerve damage? And then number two, what are we going to do about it? And the answer to that can be twofold. Or broken down into two components. What are we going to do to treat the underlying cause, and what are we going to do to treat the symptoms of this small fiber neuropathy? In terms of what caused a small fiber neuropathy, earlier I alluded to the fact that in the majority of cases of small fiber neuropathy, we do not determine a specific diagnosis. Probably in most cases that's because something has happened that has damaged the small fiber nerves. Whatever that process is has run its course and has left its damage and gone away. And so we don't find what it is because it's gone. And that's where the history comes to be very important. The majority of patients that we see in our autonomic disorders clinics with small fiber neuropathy tell a story of, I was doing well, and then I got sick, and then I maybe got a little bit better, but overall I've been about the same with my good days, bad days, maybe a good week, bad week, but pretty much the same. That's the most common story that we hear. And that tells us that something happened. But another story is, I was doing well, and I got sick, and I keep getting worse and worse and worse. And a story like that is going to make us look a lot more aggressively for those things that cause a progressive small fiber neuropathy. And in the adult population, we're really thinking about autoimmune conditions predominantly, though we don't close our eyes to the other potential causes. In terms of what additional tests should be expected, again, it really depends on the clinical scenario. The tilt table test and the sweat test may be sufficient if someone has a chronic and stable small fiber neuropathy. I think most of us, even in patients with a chronic and stable small fiber neuropathy, would do basic screening labs looking for general physical conditions, including autoimmune conditions that could cause a small fiber neuropathy. And in the adult population worldwide, the most common cause of a small fiber neuropathy is diabetes or even pre-diabetes, so early diabetes before the full diabetic syndrome has appeared. So looking for that is important. Lauren or anyone else, any follow-up questions or comments on that topic?
So folks, I have a lot of questions that people have typed into the dashboard, and I don't think you can see that, so I will ask you the questions. I just ask everyone to understand there's tons of questions and we can't get through them all, so I'm going to try to take topics that are very on point for the discussion of rare dysautonomias or things that might apply to a lot of people asking similar questions. So we've got a bunch of questions about the relationship or non-relationship between Sjogren's and AAG, and sort of the simplest question is Sjogren's with the dysautonomia the same thing as AAG?
Yeah, so AAG, autoimmune autonomic ganglionopathy, is a very distinct disorder in which that autoimmune autoantibody blocks the communication between presynaptic and postsynaptic autonomic neurons. And it produces a pan-dysautonomia. And people with AAG are pretty sick. And AAG really is a rare condition. Sjogren's disease causes damage to the small fiber nerves directly. So in Sjogren's disease, you're going to see a more typical small fiber autonomic or sensory neuropathy. People with Sjogren's disease, because they have very dry eyes and dry mouth in most cases, share that with autoimmune autonomic ganglionopathy. I remember the first patient that I saw with AAG described to me that his dry mouth was so bad that when he would chew a stick of gum, it would just turn to dust. So he had very profound dry mouth. So that dry mouth and dry eyes is something that people with Sjogren's disease and AAG share. But in terms of the part of the peripheral autonomic nervous systems that they affect, no, they are different and diagnosed differently.
Okay. As a follow-up AAG question, can you have AAG without the ganglionic acetylcholine receptor antibody?
So is there antibody negative AAG? The answer is probably, but I would, without evidence that there is a ganglionopathy, a problem at the ganglia, I would be hesitant to go forward with that diagnosis when the neuropathies are so much more common. But yes, we do have some evidence that there probably are autoimmune ganglionopathies caused by things other than the nicotinic cholinergic receptor that we can test for.
The next question is about Behçet's, and I apologize if I'm saying that wrong. So this individual is saying that her Behçet's is in remission, but she's having a sudden kick, flare of dysautonomia. Is it likely that this is the Behçet's, or is it possible that there's just something unrelated? And I know you can't give specific medical advice, so obviously this patient needs to talk to their doctor about their own particular case. But just in general, how does Behçet's cause a dysautonomia?
I think probably the best answer to that is to how does Behçet's cause a dysautonomia is we don't know exactly. Whatever is going on with the dysregulation of the immune system in Behçet's, it's damaging the tissues of the body. People with Behçet's, the what clues us into the diagnosis of Behçet's disease is someone develops recurrent ulcers in their mouth and around their genitals. But the inflammation in Behçet's disease affects many other parts of the body as well. And when it affects the neurons, people can develop, or when it affects the nerves, people can develop a neuropathy. So yes, I think the concern in someone with a diagnosis of Behçet's who's having worsening of autonomic symptoms, the question I would ask is there a worsening of the autonomic neuropathy? And that is something that should be looked at by the person's medical team.
Okay. The next question is, there's a couple folks who've asked about mitochondrial disorders, which tend to be pretty rare. Are there specific mitochondrial disorders associated with dysautonomia, or more broadly, mitochondrial dysfunction that may not be a specific genetic mutation? Can you talk about that a little bit?
I think this is a challenging one currently in the world of autonomic disorders. Certainly there are many neuropathies that are associated with mitochondrial dysfunction, and I think I don't know enough to talk specifically about any specific mitochondrial conditions, but I think it is worth saying that we get concerned about mitochondrial disorders when we see multiple organ systems being affected. So when we see skeletal muscle being affected and the nervous system being affected, or the brain affected and the heart affected, we get concerned about mitochondrial dysfunction. And typically we then turn to laboratory tests to give us evidence of mitochondrial dysfunction, and those laboratory tests are pretty routinely done in blood and urine samples. They are not too exotic of tests, so people can get those done pretty easily if there's a concern.
Okay, the next question is there a relationship between anti-nuclear antibodies and dysautonomia?
So anti-nuclear antibodies are non-specific markers associated with a variety of autoimmune diseases. And there are different tests that can be done for anti-nuclear antibodies, and some of them lead to more false positives than others. So a preliminarily positive ANA does not necessarily give you a diagnosis of an autoimmune or connective tissue disorder, but many of the connective tissue disorders can be associated with neuropathies and with small fiber neuropathies. So a positive ANA does need to be followed up on to look for evidence of an autoimmune or connective tissue disease.
Okay. The next question is, in a patient who has been diagnosed with AAG, the patient's doctor has recommended IVIG. The patient is asking, what would you do to promote cholinergic signaling?
Mm-hmm. So there are lots of medications that can be used to promote cholinergic signaling. The most common one that we're going to use is pyridostigmine or Mestinon. So Mestinon is the brand name, pyridostigmine the generic name, and pyridostigmine works by stopping the breakdown of acetylcholine in that synaptic cleft. So that's how we're most going to promote that synaptic cholinergic communication. We can also treat some of those cholinergic symptoms of autoimmune autonomic ganglionopathy by using medicines that act directly on the cholinergic receptors. And those can be very helpful in treating some of the other symptoms of AHE.
Okay. The next question is about a topic that is probably not rare related, but it's a good question just in general. So What about things like accidents and injuries and concussions? Can that result in dysautonomia?
Maybe. We don't know. Definitely a topic of interest. Definitely after people have severe brain injury, we see a lot of autonomic dysregulation. So as that central autonomic network that we talked about gets damaged and the communications between the components of the central autonomic network get cut off from each other, and the communications between the central autonomic network and the peripheral components of the autonomic nervous system get disrupted after traumatic brain injury, we see those effects in terms of autonomic dysregulation. For most people who are not in the intensive care unit because they've had a severe traumatic brain injury, they're dealing with a more mild traumatic brain injury, and a variety of symptoms can come on. When we look at people with concussion, we do have pretty good and pretty consistent evidence across multiple small case series that there are measurable effects on the regulation of heart rate after concussion. So after someone's concussed, we do see that the way heart rate is regulated is affected. That's definitely something that in my own personal bias is it should be studied more. In terms of frank clinical symptoms, though, we don't have enough information in the medical literature to say for certain. So, can someone's POTS be caused by a concussion? We don't know enough to say yes at this point. However, anecdotally, we see a lot of patients who do trace their symptoms, at least the onset or worsening of their symptoms, to a concussion. So while I think the answer is probably yes, that's something that we need to explore more, and we can talk more offline about putative mechanisms of autonomic dysfunction after concussion.
So separate from concussion, although sometimes together, what about autonomic dysreflexia in spinal cord injury?
Yeah, it's a common problem, and we, after spinal cord injury, we often see that autonomic dysregulation early on, where there are wide variations in blood pressure, heart rate, and later on, as the damage becomes more chronic, we're more likely to see problems with drops in blood pressure as people start to stand up. So yes, autonomic dysregulation after spinal cord injury is common.
Okay. This person says this may be a really broad question, but what diseases are associated with, the person says AChR antibodies. Obviously there's different types. And can you explain the difference between the myasthenia gravis antibodies and the AAG antibodies?
Right. So let's go back to our picture here. So myasthenia gravis is a condition we didn't talk about, but myasthenia gravis is an autoimmune disorder in which there are antibodies against the acetylcholine receptor on the muscle membrane. And myasthenia gravis can also be associated with antibodies against other proteins that are associated with this muscle membrane acetylcholine receptor. The acetylcholine receptor on the muscle membrane is structurally similar, but still different from the acetylcholine receptor at the autonomic ganglia. So the acetylcholine receptor at the autonomic ganglia has a very specific structure, and the autoantibody in autoimmune autonomic ganglionopathy is actually targeted against one specific subunit of that acetylcholine receptor of the autonomic ganglia. So it's the acetylcholine receptor of the autonomic ganglia, again, is structurally distinct from the acetylcholine receptor at the effector sites of parasympathetic nervous systems, and those are different from the acetylcholine receptor that we see on the muscle. And so the antibodies that affect them are different. If someone has an antibody just against the acetylcholine receptor on muscle, they'll develop muscle weakness. If someone has an antibody against the acetylcholine receptor in the autonomic ganglia, then they develop autoimmune autonomic ganglionopathy.
Someone has a question about diagnosis of Lambert-Eaton myasthenic syndrome. Is it diagnosed with just a positive PQ type calcium channel antibody, or are there other things that have to be present? And when you're answering this, I know that a lot of POTS, not a lot, but a subset of POTS patients have some sort of like non-specific Mayo Clinic antibody panel coming back positive, where it's low titer, or it's the antibodies present without all the major symptoms of the other disease. So can you talk about that a little bit? How these things are distinguished? It's, is it just the antibody that has to be there, or is there more to the diagnosis?
Right. For Lambert-Eaton myasthenic syndrome, you really do have to have that muscle weakness there. And then if there's a question of is the muscle weakness there or isn't it there, then the electrodiagnostic testing can be done with repetitive nerve stimulation. And then again, the autoantibody, if it's just a low titer, the low titer is probably not meaningful.
Okay. Can you discuss the relationship between lupus and dysautonomia? Keeping in mind that lupus is not a rare disease either, but it's just a good question that came up.
Right. So lupus is another autoimmune condition that can be associated with nerve damage. Just like it can damage tissues throughout the body. In lupus, the nerve damage is probably in most cases due to damage to the small blood vessels that provide a blood supply to the nerve. That's one of the things that we look for, because we know that it is a not too uncommon cause of autonomic neuropathies.
Okay. And then this individual is asking, what blood tests can be done to check catecholamines?
Yeah. That's what it is. You measure catecholamines in the blood. And so catecholamines and the broader category of catechols can be measured in blood samples. Some of the catechols are trickier to measure than others, and there are a few labs that perform that testing commercially. I obviously did my training in the clinical neurocardiology section at the National Institutes of Health, where Dr. Goldstein's lab does excellent neurochemistry work, and is able to be a great resource for testing catechols in the blood and in other tissue samples. So it's a simple measurement that's available at multiple labs.
Okay, and this is I think probably the last question we'll do, and it's a good one. It's one that is definitely a controversial, where there really isn't a great answer. But this individual is asking, is Lyme disease, or there's a couple of individuals asking about it, is Lyme disease a cause of dysautonomia?
So I think that is a good question. Yes, Lyme disease can be associated with nerve damage in general, and it probably in some cases can cause an autonomic nerve predominant neuropathy. I think this question comes up a lot more when thinking about the chronic symptoms that can appear after Lyme disease. And there are probably enough people who develop autonomic symptoms after exposure to Lyme to suggest that there is something about the disease that can lead to a longer-term syndrome, even after the infection is treated. So I'm not talking about an ongoing infection that needs ongoing treatment, but either a neuropathy that may be there, and I think that's something that can and should be explored more. But I think to talk specifically about the idea of chronic Lyme and ongoing treatment with antibiotics over a prolonged period of time, I don't think we have evidence that would support a course such as that.
Okay. I'll take one more last quick question. Antiphospholipid syndrome and its numerous related antibodies, can these be associated with dysautonomia, separate from lupus? Sorry, go ahead.
I would say in terms of possible mechanisms, yes, probably. In terms of numbers, I don't know how often that has been described.
Jill Schofield is a doctor who's very interested in antiphospholipid syndrome, and she was at our conference last year. I was asking if you had seen her presentation. I didn't know if you had. In her clinic, which is very heavy on the antiphospholipid syndrome patients because they seek her out for her expertise in this, she had said, I don't want to be quoted wrong, I don't want to say it wrong, but I think it was about 12% of her patients that had an overall dysautonomia of some sort had some of the antiphospholipid antibodies, and that she thought that this sort of correlated to people with more severe migraines. And so it's definitely a new area that needs some research.
Right.
Just having the antibody itself doesn't mean you're going to end up with dysautonomia.
Right. I like you said, I think that's evolving. I can tell you, I ordered antiphospholipid antibodies today in a patient that I saw in clinic, but again, an evolving, yet another evolving portion of our world.
Okay, I absolutely promise this is the last question because it's 9:30. You are in the military health system. Are there other doctors on the West Coast that patients who are in the military medical system can see for their autonomic disorders, or should they try to get to you if their case is not being managed well locally?
Great. I'm glad you brought that up. We did have that one question that came up earlier that was specific to the San Diego area. There are not other autonomic disorder specialists within the Department of Defense, within the military healthcare system. Many of our neurologists and cardiologists do a very good job with patients with autonomic disorders, and so I would start there. Definitely, my colleagues do reach out to me in the more challenging cases, or if they have specific questions. So I am available as a resource to physicians throughout the military healthcare system, and our clinic here in Portsmouth does see referrals that that need a higher level of care. So the answer is start locally, and I remain available as a resource. Out on the West Coast, I would start with the neurology department at Naval Medical Center San Diego, in terms of Navy, and then further up on the West Coast if someone's up in the Northwest, Madigan Army Medical Center.
Okay. Well, thank you so much for your time and expertise. And you can't hear them, but everybody else is saying thank you too. And I hope that everybody will join us. We're doing these webinars monthly on all different topics, and we'd actually love to hear from people on what topics they'd like to hear future webinars on. So that'll be it. We'll send out an email to everyone in the coming days that has a link to the recording in case you missed part of it or you want to share it with someone else. And we'll be posting it on our social media pages. So thanks, everyone. Have a good night.
Good night. Thank you.